Thank you for joining us for the Subcommittee on Health and Professions of the Senate Committee on Education and Health. As we begin, it looks like our last member is on his way in. If you would take the roll, Clerk.
Senator Prakarsky. Here. Senator Head.
Here.
Senator Bagby. Here. Senator Pillion.
Here.
Senator Boysko.
Here.
You have a quorum, Madam Chair.
Thank you. We have a little bit of housekeeping to do first. We have two bills that will be going by at the request of the patron. Senator Stewart's SB 331. Do I have a motion?
So moved.
Second? All in favor of going by for the day? Do I have to do that? Aye?
Aye.
Okay. And any opposed, right? Next, Senator Durant has asked that SB 403 goes by for the day.
So moved. Second.
All righty. All in favor? Aye. Thank you. We have two bills that will be re-referred to the courts of justice.
Okay, can we make that one? Sorry.
We have one bill that will be re-referred to the courts of justice, and that would be Senator Hashmi's SB 278.
So moved. Second.
All righty. Can you open the rolls? Do we have to?
No, it's a subcommittee.
It's just a voice vote. All in favor of that? Aye. All righty. That leaves six bills that we have in front of us. Senator Locke, you are first up. Which do you prefer to begin with?
And there are two technical amendments.
Okay.
Move the amendment.
Second. All in favor? Aye.
The technical amendments on line 133, which is in Article 3, subsection A. When referring to the dental education programs, we're changing leading to the specific degrees mentioned to resulting in the degrees mentioned. And then again on line 176, in Article 4, subsection A, when referring to certain education programs, we're changing leading to resulting in.
Okay. Senator Locke.
Okay, Senate Bill 22 adds Virginia to the list of states participating in the Dentists and Dental Hygienists Compact. The compact is an initiative of the U.S. Department of Defense and the Council of State Governments, the American Dental Association, and the American Dental Hygienists Association. It is supported by the Virginia Dental Association, the Virginia Dental Hygienists Association, the Association of Dental Support Organizations, and many other groups. The Dentists and Dental Hygienists Compact utilizes a compact privilege model of interstate practice. To utilize the compact, a dentist or dental hygienist must have a license in good standing in a state that is a member of the compact. When a licensee wants to work in another participating state, the licensee obtains a compact privilege. The compact privilege model allows a participating state to continue to determine the requirements for licensure in that state, as well as to maintain that state's unique scope of practice for all members of a profession practicing in that state, whether through a state-issued license or through a compact privilege. The compact helps military spouses relocate and begin work without delay by reducing the amount of time and effort needed to gain authorization to practice in a new state, even as compared to expedited licensure laws for military spouses. Overall, the Dentists and Dental Hygienists Compact will support military families, improve access to and continuity of care for Virginians while ensuring the sharing of investigative and disciplinary information among participating states to protect the public. I have several individuals here who would like to speak for the bill. Madam Chair.
Thank you, Senator Locke. I understand that we have a number of members of the Virginia Association of Dentists in the room, and we're so happy to have you all here. Do any of our members have any questions? All righty. Do you have some speakers who would like to speak in support of your bill? Let's start with that.
Yes, ma'am. Madam Chair, Chris Nolan, excuse me, with McGuire Woods on behalf of the Association of Dental Support Organizations. I want to thank Senator Locke for bringing forth the compact. This was developed by the Council of State Governments over a 2.5-year period with robust input from various stakeholders. It has wide support within the larger dental community. It has passed in 3 states. It passed in the 4th last week, Wisconsin. It's awaiting the governor's signature there, and it's pending in 11 states, including Virginia. When the 7th state adopts it, then it comes into effect. And you've seen this concept before in the other compacts that Virginia has joined, such as psychology, physical therapy, counseling, occupational therapy, and others. And the compact sets forth the requirements of how the commission is formed, the database of the compact privilege holders. And the reason we're asking Virginia to be an earlier adopter of this is so that Virginia can have a seat at the table at the commission when it's formed so that we can participate in writing the rules of the commission. Senator Locke said that this is a compact privilege, and it's just that. It is a privilege that can be revoked if the Board of Dentistry finds that a holder of the privilege practicing in Virginia violates scope of practice or any other patient care or other requirements that Virginia has for a practicing dentist. So, for instance, if Virginia requires a permit for sedation, you still have to go to the Virginia Board of Dentistry to get that permit for sedation. This privilege can be revoked. And the great thing about the compact is it preserves that state sovereignty to implement its requirements for licensure in Virginia. And we urge you to support it. It promotes flexibility and mobility, and thank you.
Thank you so much.
Madam Chairman, members of the committee, good morning. I'm Scott Johnson. I'm General Counsel to the Virginia Dental Association. We stand in full support of this legislation, ask you to support it and pass it. And Madam Chairman, with your permission, we've got a number of dentists and dental students here today. I would ask them, if okay with you, that they please stand, or if they're standing, to raise their hand. Thank you.
Glad to have y'all here. Thank you.
Forgot about.
Yeah. Next.
Madam Chair, members of the subcommittee, I'm Tyler Craddock with Legislative Strategies Group on behalf of the Virginia Dental Hygienists Association. We strongly support this bill. It will, and we appreciate Senator Locke. We appreciate her leadership in bringing this issue forward, and strongly urge you to pass it. Thank you.
Are there members of the audience online who wish to testify in support? No one? We don't do that? Okay. We do not allow that in subcommittee. Anyone opposed to this bill? Seeing none, do we have a motion?
Move the recommended reporting. Yeah, and I would second that. As the only dentist in the General Assembly, I think this is a great bill that Senator Locke has brought before us, and yeah, I second that.
Excellent. Clerk, if you'd open the roll. Oh, it's... All in favor? Aye. Any opposed? Hearing none, your bill has reported with recommendations that will
Thank you, Madam Chair. Senate Bill, my next bill is Senate Bill 33, will not go as quickly. So there is a substitute.
Okay. Do we have a motion on the substitute?
So moved.
Second. Okay. Someone could explain the content of the substitute for us,
As I
please?
go through, this substitute adds language to the enactment clause regarding directing the work group to determine the impact on patients in underserved areas and whether it will increase or decrease health disparities. And what the bill itself does is 2 things. It clarifies Virginia's current law regarding anesthesia care. And it directs a work group of stakeholders and subject matter experts to meet over the next year. Despite anything that you may have heard regarding SB 33, it does not expand supervision or change current practice. Current law requires CRNAs to practice under the supervision of any type of physician, dentist, or podiatrist. There have been concerns that the law is vague and leads to confusion amongst facilities and providers. The bill addresses that because it will clarify the current law by defining supervision to capture what is already happening throughout Virginia. I will say that again. This does not change current practice or supervision requirements. As I'm sure you've learned by now, there is much disagreement on whether the current law should be changed. Therefore, the second part of the bill directs stakeholders to meet over the next year to discuss and make recommendations. And those recommendations can be, what ways to increase the anesthesia provider workforce. This includes determining how the current law impacts workforce and if licensing anesthesiology assistants will help or hurt that. And most importantly, it directs the work group to assess how potential changes would impact patients in our underserved regions. Normally, I don't get involved in this scope of practice stuff. That's not my thing. But I'm sure but I am this time because anesthesia is different. While rare, when things go wrong with anesthesia, they can be life-threatening, and every second matters. When the stakes are that high, we need to take our time and do our due diligence before changing anything. This bill begins that process by forming a work group to do just that. These folks need to talk to each other rather than talking past each other, or at each other. So I'll ask my chief co-patron, Senator Pillion, if he would like to speak to the bill.
Work with anesthesiologists and CRNAs. I'm intimately familiar with this issue. I value the skill set of each of them. I think the current law works, and it works well. And as a provider in Southwest Virginia, I'm particularly sensitive to the challenges that we face in rural Virginia and access to health care. So I can definitely tell you that this bill will not impact or hurt access to care, and if it did, I wouldn't be supporting it. So I think it's quite the opposite, and that's why I'm a co-patron of this bill, because I believe the current supervision requirements are appropriate, and they actually help ensure access to care for patients in our underserved areas.
Madam Chair, I have individuals here who are here to speak to this bill. And
Thank you. Thank you, Senator Locke. If you'd like to bring your witnesses up in support of the bill. And thank you, Senator Pillion, for your comments. Yes, if you'd introduce yourself and tell us how you feel about the bill.
Good morning. Madam Chair and members of the subcommittee, my name is Dr. Alice Coombs. I am speaking on behalf of the Medical Society of Virginia and the Virginia Society of Anesthesiologists. I am also chair of the Department of Anesthesiology at VCU and also serve as president of the Medical Society of Virginia. As you've already heard, thank you so much, Senator Locke. This bill does two things. It clarifies the current law defining supervision. It does not impact current practice. As you've already heard, we believe the current law works and has allowed patients from every region of Virginia the ability to access quality care. With that said, we do understand that there is a desire among some of our colleagues to look at the current law and find areas of improvement. Virginia Society of Anesthesiologists is very willing to sit down with our colleagues and our other stakeholders and discuss some of the issues that come up. This bill creates a work group, stakeholders, to do exactly that. We strongly believe that when it comes to something as complex as anesthesia, any changes to the current model of care deserves a thoughtful, comprehensive approach that includes all stakeholders at the table. We're not going to find a solution in just one meeting. And a question we must all ask and discuss before making any changes in the standard of care is how will we impact the low-income, underserved patients? Addressing health disparities and improving health equity is my life's work. I grew up in Compton, California in the 60s and did my residency at Harvard. I worked in several states. I know firsthand health care inequities that exist across areas of medicine. And I've seen what happens when well-intentioned laws have unintentional consequences. Right now, patients in all areas of Virginia have access to physician anesthesiologists and CRNAs. The individual circumstances of that patient's case will be determined with appropriate care, which is based on the standard of care guidelines. Anesthesia always carries an inherent risk, even with the healthiest patients. But that risk does increase when patients have comorbidities and are undergoing complex surgeries. We need to make sure any changes in current law that take into account all of these recognized complexities. It would be unfortunate to place some patients at risk and provide them with no choice of models of anesthesia. That's why I hope you will support this bill, which clarifies the current law and gives the stakeholders an opportunity to discuss these important issues. Thank you very much. Thank you.
Thank you very much. Other speakers in support of the bill?
Good morning, Madam Chair, members of the subcommittee. Lauren Schmidt on behalf of the Virginia Society of Anesthesiologists. I just want to reiterate that we want the opportunity to sit down with everyone, all the stakeholders. It's not just anesthesiologists and nurse anesthetists, it's dentists, it's surgeons, it's hospitals, patients. We want a formal process to be able to go through all of this and figure out a solution. So appreciate you hearing our bill today. Thank you.
Thank you so much. Other speakers in support of the bill? Ms. Schmidt, I have a question for you. In the work group, you on line 134 through 136 talks about the projected impact of licensing anesthesia assistants who are currently in anesthesia provider workforce in the Commonwealth. Can you help me understand exactly what an assistant anesthesia provider is and how they are different than a nurse anesthesia, a CRNA? Excuse me, I get my letters mixed up.
Yes, Madam Chair, thank you. So an anesthesiology assistant is another anesthesia provider. They are not currently licensed in Virginia. They are licensed in some other states. And it has been an issue that has come up over the last couple of years of whether we would benefit from having that or not. It is another contentious issue, and so that's why we threw that into the work group as something to discuss, along with the concept of do we need to change the supervision requirements regarding nurse anesthetists. It's just an issue of many that we would like to look at. As far as explaining the difference, do you mind if I defer to one of the experts?
I'd be delighted.
Okay.
Thank you.
Dr. Coombs?
So currently there are 42,000 anesthesiologists in this country, and there are 46,000 CRNAs. There's less than 2,000 anesthesia assistants. But in places like Georgia and other states, they have helped to meet the needs of operative demands by actually developing anesthesia assistant programs. It's indistinguishable from CRNA programs, and right now surgeries are being delayed because of some of the anesthesia providers in the area, and especially where there's malrepresentation in some of the areas. So that is something that should be explored and discussed going forward.
Doctor, one follow-up question. I think I heard you say that there is no distinguished difference between CRNAs and an anesthesia assistant.
And in the clinical space.
Could you help me understand?
So you start your day as an anesthesiologist or CRNA or an anesthesia assistant by doing essentially the same thing. They will, the operative capacity for what they do throughout the day is indistinguishable.
Would you mind if I ask you another question? I would like to understand the scope of training between the two.
It is different. CRNAs do require, in the current work environment, a PhD, whereas an anesthesiologist assistant does not.
What level of training does an assistant
master's
require?
programs and then a training program after that. And they're variable. Some people do have PhDs who are anesthesiology assistants, and some do not. But it's not a requirement.
Thank you for your questions. May I hear from the audience if you have opposition to the bill?
Madam Chair, members of the committee, Michelle Satterland on behalf of the Virginia Association of Nurse Anesthetists. We represent the 2,300 licensed advanced practice registered nurses who are licensed in the category of nurse anesthesia. We do not oppose the work group portion of this bill or the new language related to diversity and equity. We think those are important topics. We are happy to get together in a work group. But what we are very much opposed to is the section of the bill on the substitute, lines 22 through 24, that from our perspective further expands supervision requirements. CRNAs are the predominant provider of anesthesia in the rural areas. Requiring that a physician be immediately available would have harmful impacts. I am not a clinician. We have 3 different clinicians who are here to really explain that to you. I know there's been a lot of discussion about this, and we want to make sure that you fully understand what this bill does and the impacts it will have on our anesthesia provider workforce. And Senator Boysko, if you'll indulge me a minute, we also have from the Nurse Anesthesia School students who have joined us here this morning, and I would ask that they raise their hand.
Thank you so much.
Thank you.
Welcome. Happy to have you all here. Are there other witnesses?
Good morning, Madam Chair, Subcommittee. Thank you so much for the opportunity to be here today. My name is Nikki D'Amico. I've been a CRNA in the state of Virginia for 24 years. I'm a very proud VCU alum, and I must add I currently am the Herbert T. Watson Endowed Chairperson of the Department of Nurse Anesthesia. I am not speaking on behalf of the institution. I'm speaking as a person who has nearly 3 decades of experience in nurse anesthesia education. I know very well what the training programs entail, their training requirements, and the challenges that we face in those areas. I also work in a rural area where this specific change in the language would very much affect my practice at that institution. There are currently 3 programs in the state of Virginia. We have some very highly regarded programs. In fact, the Virginia Commonwealth University program has been ranked #1 in the nation for more than 2 decades by the U.S. News and World Report. We do not have a problem recruiting students to come and train in Virginia. Across the 3 programs, we turn away 3 to 4 highly qualified students for those training spots every single year. We are ready to increase capacity at those programs. There's an absolute willingness and capacity to increase. We have been doing that steadily, but we've not had specific conversations with folks to talk with us about that. We are happy to do that. We have the capacity, ready, willing, and able. The limiting factor is the training slots, the number of slots that we are allowed to have, and the quality of those slots. And when I say that, I mean that in some institutions, particularly those who employ very restrictive practice guidelines, they limit what the nurse anesthetist and the CRNA students can do, or SRNAs. So that is the rate limiting factor. Senate Bill 33 would create a direct and indirect. It would raise that barrier. It would make it increasingly difficult for us to get those training slots. We cannot compromise our standards. We have extremely high standards for training in nurse anesthesia programs. It's a 36 months, 3 years, above and beyond having, at this point, 2 to 3 years a minimum of critical care experience in the ICU, plus having a bachelor's degree in nursing. So we've been in this for a long time. Despite those rigorous training programs, we have to send them to places where they can get to do those things. If they don't get to do them at that particular restrictive place, we also have to send them to another place out of state. They go out of state, and they get to train in a less restrictive environment. And like one of our students, Barrett Haynes, who just graduated, she's going out of state, longtime Richmond resident. She's leaving the state because she's going for the opportunities that other states offer. I ask you to please vote against Senate Bill 33. We're not opposed to the study, but we would like to please strike that language.
So we have some questions for you from
Yes.
my colleagues. Senator Head, address your questions through the chair, please.
Yes, thank you, Madam Chair. My question is, I mean, first of all, I'm a little, just as a statement preceding the question, I'm a little perplexed with some of the consternation over inserting a definition on supervision, because as I recall, with the legislation that was brought forward last year, one of the concerns was that the absence of a definition of supervision led to ambiguity, and we needed to define that. So now we've got a definition, and now there's all kinds of angst on this. But my question is, when we're dealing with anesthesia, and I don't know, because I don't work in this space. I work in the home care space. When is there ever anesthesia administered that does not involve a procedure that is going to be performed by either a doctor of medicine, doctor of osteopathy, a podiatrist, or a dentist. When else would you administer anesthesia?
We are talking about very specific situations, and I believe my colleague Meredith Joyner, who is also here representing, will speak to that point very specifically, and I'd like to allow her the opportunity to do that if that's all right.
I'm sure that'd be fine with me. I really need some clarification on that.
My name's Derek Owens. I'm a professor at Mary Baldwin University. I was a lieutenant commander in the United States Navy and provided anesthesia services in the Navy. I provided full aspect of anesthesia care and full services to 10,000 Marines on a ship in the South China Sea, 10,000 Marines in the Sahara Desert, and was the sole anesthesia provider on call for military treatment facilities in the United States. After I got out of the Navy, I was in California. Same thing, full practice, full scope of care, and then in Arizona as well. Due to my wife as a working employee as well, and job opportunities, we moved to Virginia. When I moved to Virginia, I realized this was the first place I've ever lived or ever worked where my practice is going to be restricted by state law, state legislation. Now I'm one of the 26% of CRNAs who are licensed in Virginia but do not practice here. So I leave Virginia so that I can continue to practice to my full scope, continue to do the procedures that I've been trained and practice doing, so that I can provide that care to the patients.
And so I believe that Senator had a question specifically.
Oh, do you want to answer the question? I'm
sorry.
sorry.
And Senator Pillion also has a question, my understanding is. So addressed through the chair, please.
If you would indulge me to speak, I think I can help address your questions. So my name is Meredith Joyner, and I've been a CRNA here in Virginia for over 25 years. I'm not only an anesthesia expert, but I'm a healthcare quality expert as well, as I work for an accreditation agency for ambulatory surgery centers. I'm here today representing facilities and physicians. There is a lot of opposition to this bill, Senate 33. I have 25 letters representing over 60 Virginia physicians and dentists who will speak to the high quality care that they get from CRNAs. These are the ones that know about the bill. Dentists, oral surgeons, urologists, plastic surgeons, women cancer surgeons, eye surgeons, general surgeons, OBGYN, the list goes on. Putting more restrictions on CRNAs will affect their practice and their safety. This is what the bill says. Supervision means a physician, dentist, or podiatrist is present during the operation or procedure or must be immediately available. The new words are present and immediately available. This bill does not affect facilities who work with physician anesthesiologists. This bill affects facilities that work with CRNA-only anesthesia models. Hospitals in rural areas.
Madam Chair?
Senator Head.
I don't mean to interrupt, but that's not what the bill says. The bill doesn't say and, it says or.
Or. Present or must be immediately available. So you either have to be present while we're working or immediately available. That's the new words.
Yeah, Madam Chair, but to reiterate my question, what procedures are you being anesthetized for that do not involve one of these professions that's already listed here?
I'm going to give you an example.
Speak through the chair, please.
Yes, Senator Head, please let me give you an example. In a CRNA-only facility, which I can list here for you, and I will, I'm going to give you an example. Derek and I are CRNAs. We work in a CRNA-only practice. He's in the holding area, the pre-op area, doing blocks. I'm in the back with the orthopedic surgeon. If the orthopedic surgeon is the supervising physician, which he is the way the law is currently set, Derek cannot provide because he's not present or immediately available. He's in the back fixing bones. So if the patient needs CPR in the holding area, the supervising physician is not present or immediately available because he's in the operating room with me.
Madam, are there further questions from the members?
Not for her.
Okay. If you continue your...
Okay,
and we
so
have several other bills today.
In this facility, there are Corellia Franklin Memorial in Rocky Mount, Giles Community in Pierresburg, Bon Secours Southampton Medical Center in Franklin, VCU Community Memorial in South Hill, just to name a few. Those orthopedic surgeons, the dentists, the general surgeons, they're the supervising physician. Do I need to turn around and look to see if a physician is present or immediately available if I need to do CPR on you and you're in the holding area? That's what the law says. Here's the last thing. This, Chairman, this bill belongs to physician anesthesiologists. Why is one provider trying to restrict another provider? I can't understand why you guys didn't come to us and talk to us or have these conversations with us. We are 2,300 CRNAs. We are trained to work independently, and that's what we should be doing. It takes 10 years to become a CRNA.
Ma'am, you need to speak to
Thank you.
to me. I'm the
Yes,
chair,
I'm sorry,
and
excuse
all
me. Yes, ma'am.
communication should go through the chair.
I'm sorry,
You need to
excuse me.
send it to me, please.
Yes, I urge, we do not oppose this work group study. This was studied in 2017. We didn't do what was supposed to be done in 2017 to make the changes, and I urge you to have the conversations with us before this bill leaves this room. Thank
Senator
you.
Pillion?
Okay. So how would this bill,
Senator Pillion, if you'd address it through the
Sorry.
chair, please.
Madam Chair, my question to the speaker is, how would this bill specifically impact their current practice?
Thank you. If you'd answer
Yes.
The way
the
you
senator's question.
Madam Chair, the way they currently practice, how would this bill before us impact them?
Thank you for the question. If you'd please
Yes.
answer the question.
In the scenario that I described, where Derek is providing blocks, there is not a physician present or immediately available while he's doing blocks in the holding area. That supervising physician is in the operating room. It would change the practice. You would have to have a physician, podiatrist, or someone to basically stand out there and wait to provide care if Derek needed it. That's the way the wording says, present or immediately available.
Senator Pillion, do you have a follow-up question?
I do not.
Thank
Not
you.
this time.
Thank you. I appreciate your testimony. I know
Yes,
means
I understand,
this is an issue that we're trying to work through. I would say that over the fall, we did have a conversation with the two parties and tried to work through a little bit of this work. So this is not the first time that we've brought everybody together. Are there other people who you brought in opposition? So there is discussion amongst
I do have a question.
the members. Yes, Senator Pillion.
Michelle, so, we've talked about this bill. We've talked about this bill, and Senator Locke and everybody on this committee can probably tell you we've talked about this bill for a while now, for many years. And Senator Locke, you've asked for supervision, a definition of supervision. We've given you a definition of supervision. You're not happy with it. My question is, and you said you want to work with the anesthesiologist. When did you receive this language?
Madam Chair, we received this language in December. And
Okay.
we had a stakeholder meeting, talked. This is the meeting that the senator is referencing. We could not find compromise. This language came to us after we indicated that we would be introducing in the House a bill to remove supervision. The minute we announced that, this bill showed up. So there's some strong feelings about this. And I understand Senator Pillion, and I know the work, or Madam Chair.
Madam Chair.
Sorry. I understand the strong feelings, but I think that the really important piece here is over the last year, the Commonwealth of Virginia has spent significant resources and time looking at the workforce shortage issue. The Virginia Workforce Authority, their report came out in September 2023, and it said the restrictive rules in Virginia can have an impact on recruiting nurse practitioners, which we are. Additionally, the 2023 report from the Department of Health Professions echoed those same words. These are experts that are not anesthesiologists or nurse anesthetists. These are unbiased third-party researchers. If they see that this is having an impact on our ability to recruit, to maintain, and to ensure safe access to anesthesia care, I think that's who we should listen to. This bill goes against those recommendations. It goes against the national trends, and that is a significant concern.
I have a question, and this is another hypothetical situation that would possibly occur. I am in a rural area. There are not doctors, and I have gone to a clinic and I'm in labor. Would I have the ability to get a epidural before the doctor arrived if there is no doctor present when I'm starting to go into labor? Would somebody be able, and I wouldn't mind if our anesthesiologist spoke to that to help clarify this. I think that the crux of this is that Senator Locke wants to make sure that everybody has access to adequate health care that is high quality and that is going to reduce mortality. I very much appreciate the reason that you brought this forward, but this is complicated. If the doctor would speak, please, about that hypothetical situation.
Thank you very much. Alice Coombs, representing VSA and MSV. So it depends. At CMH, which I am also over as well, there are CRNAs who work independently, and they do that around the clock. And so you could get an epidural by a nurse anesthetist. You may not get one by a physician. And part of the concern is in rural-based areas, they will have nurse anesthetists that clearly do epidurals unsupervised. And so the high-risk patients are a concern for us, and it really involves early engagement for these high-risk. As you know, maternity mortality in Black women is at an all-time high. So we are concerned about that piece of it, but the answer is, in rural-based areas, it is the CRNAs will many times operate without physician supervision or oversight, or a physician might be the obstetrician who's actually the physician of record.
So I think that this is the question I think that a lot of us have who are wondering, if there is not a physician present, this language, the way I'm reading it, says that there must be supervision must mean that the doctor is present during the operation or procedure or is immediately available. And I think that's where we're getting caught.
It says physician. It does not say anesthesiologist. So by fact that a patient is laboring in a hospital requires ACOG guidelines that a physician be on the premises.
Lauren?
Madam Chair, I just want to clarify that, again, that's current law, right? That they have to be supervised by a physician, doctor, dentist, podiatrist. This is not changing that. I wonder if Brent Rawlings is in here from VHHA. I think he can speak to whether this would change current practice.
Thank you. Mr. Rawlings, if you'd like to provide some clarity for us.
Madam Chair, members of the subcommittee, Brent Rawlings, Virginia Hospital and Health Care Association. I'm not sure I can provide clarity for you. What I can tell you is that we did share this language with our hospitals and asked them if this reflects their operating definition of supervision, and the response we got was that it did. And so from the perspective of, does this change current hospital practice, the reaction was it was consistent with and reflected current hospital practice as their operative definition determined to be necessary and appropriate to comply with applicable licensure laws. So I cannot speak to every scenario, and I think that purposes of clarity, that's we deal with this in law all the time. Words, what do they mean? Present, immediately available, and it's not until you get to the granular level that you can get true clarity. But again, we did not see that this language would affect an immediate change in requirements for supervision in current practice.
Thank you for that.
May I answer your specific question, Senator? Or no?
I would let the patron give us the final word. We have 5 other bills that we have to get to in the next
Madam Chair, you have the bill
minutes.
before you.
Yes, ma'am.
I think that it has been thoroughly explained what the plan is. Senator Head actually did ask the question in terms of, you've heard this before, you heard it last year. You either want supervision explained or you don't. And the bill does call for the parties to get together to say exactly what it is that they want. And this has been out there since December. And there's been plenty of time for discussion relative to these issues, and they will have time to actually get together over the interim to actually define exactly what it is that the 2 parties want.
Entertain a motion. Any other discussion on? I think we've really thoroughly vetted this for today. Is there a motion on the bill?
Report and full. Recommend reporting to the full committee.
All righty. I think if we would like to call the roll.
Senator Prakarsky? Abstain. Senator Head? Senator Bagby? Senator Pillion? Senator Boysko?
I'm going to abstain too.
Ayes 3, 0 noes, 2 abstentions.
Thank you.
Thank
We
you,
will
Madam Chair.
recommend that it reports to the full committee. Thank you. Next on the docket, Senator Hashmi, I see you in the audience. And would this be SB 326?
239.
239, oh, yes, sorry, yes, SB 239. Please go ahead.
Thank you, Madam Chair, and thank you to the members of the committee. SB 239 is actually quite similar to the compact that we just discussed this morning in the sense of its technical approaches, and you heard already that these interstate compacts are really beginning to address some of the critical needs that not just Virginia, but so many states have, especially in vital healthcare professions. And so this bill is the Social Work Compact, Interstate Social Work Compact, which also follows the same guidelines and expectations as the dental compact that this committee just reviewed and discussed. And so it is interstate compact that's coming from the Council of State Governments and also very strongly supported by our Department of Defense. And it follows the same procedures of requiring at least 7 member states to join the compact. For the licensed clinical social work compact, one state has already passed it, and that's Missouri. And during this legislative cycle, there are about 9 other states that are in the process of reviewing the compact and making the decision whether or not to join it. One of those states, of course, is Virginia, and we are hopefully going to be able to be a participant in this interstate compact. One thing we know is that there is a critical shortage of licensed clinical social workers, and we have a high demand across the country for a relatively small population of folks, professionals in this particular field. In Virginia alone, we have about 11,500 in Virginia, but we have such a critical need to address areas of mental health treatment and providing the kind of services that so many in our community are needing. So this interstate compact would aid in addressing workforce shortages by increasing the availability of licensed clinical social workers, both for children as well as adults. It supports our military personnel and spouses, making it easier for them to maintain their social work licenses as they relocate and move from state to state. It also enhances the mobility for clinical social workers who meet the compact uniform licensure requirements. And one thing we want to make sure we all agree on and understand is that this in no way supersedes the regulations and the authority of what we already have currently in Virginia. And we have some folks here today who would like to speak and address the committee on this particular compact.
Thank you, Senator. If you'd like to invite your witnesses.
Yes. We have Ophelia and Alec. Do you want to start?
Thank you, Madam Chair and Senator Hashmi. Alexander McCauley, representing the Virginia chapter of the National Association of Social Workers. And I just want to thank my colleague, Chris Nolan, for explaining how the compact works for the dentist, because it's exactly the same. And this is a critical initiative to expand access to mental health services for Virginians. It's going to be very beneficial for practitioners in Northern Virginia who want to practice in D.C., Maryland. It will help alleviate shortages up there. We're in Senator Pillion's region, practitioners in Tennessee, Kentucky, Virginia will be able to practice across state lines. So thank you, Senator Hashmi, again for carrying this. And any questions, I'm happy to answer them.
Thank you so much. Is there anyone else who wishes to support the bill? Speak. Any other?
Good morning, committee members and Senator Boysko. On behalf of the Virginia Association, I'm Becky Bowers-Lanier with the Virginia Association of Community Services Boards, and for the reasons that were previously given, we are in support of the bill.
Thank
it's
you.
It's a workforce issue.
Great. Thank you so much. Is there any did you have? Well. Go ahead.
Good morning, Chair Boysko. I'm Ophelia von Ludwig, and I'm a licensed clinical social worker. I represent the Virginia Society of Clinical Social Work, along with the Greater Washington Society of Clinical Social Work. I've been a social worker for 30 years, the last 15 in private practice. I see a variety of clients. I just want to emphasize a little bit of what this actually means. It actually means for the people I see who are working people, because I still take insurance. So I see nurses, teachers, firefighters, waitresses, servers. Social workers provide the mental health care that is necessary for such a healthy community. And when one of my clients goes to college, or when one of my clients goes away to another state to take care of a sick relative, I have to stop seeing them. And either they do without the care or they start all over again with someone new. I do have 2 friends who moved here, and they're social workers, and they can't practice here. So that's 2 people we could have working with us. I really appreciate your consideration of this bill. Thank you very much.
Thank you so much. Please come up and briefly show us your support. Thank you. I think we've heard that this is an important effort.
Yes. Madam Chair, this is Kat Atkinson with Voices for Virginia's Children. We're in support of the bill. Young people have been talking about needing more professionals in schools and so on. So we hope you support this bill. Thank you.
Thank you. Is there anyone in opposition to this good bill? Hearing none. Any discussion?
Make a motion to report and report to the full committee.
Okay, and second? All in favor? Aye. Any opposed? Hearing none, your bill reports recommended to the full committee for
Thank
passage.
you, Madam Chair. Thank you.
Next we have Senator Bagby has a quick one.
Yeah.
And we'll do yours. Yeah. Okay, Senator Bagby, do you prefer to stay up here?
Yeah. Thank
Okay.
you, Madam Chair. I believe there's an amendment in the nature of a substitute. Thank you.
Do I hear a motion to accept the amendment? All righty. All in favor? Aye. Any opposed? Please explain your bill.
Thank you, Madam Chair. Madam Chair, the legislation would simply require a healthcare facility to adopt and implement policies that require the use of a smoke evacuation system during any surgical procedures that is likely to generate surgical smoke. You may or may not know surgical smoke can be safely and effectively eliminated with available technologies. Captured surgical smoke is disposed of as hazardous waste. It's important to note that surgical smoke evacuation does not involve construction costs or changes to the facility's HVAC system or general room ventilation. And so that is what the bill does. It's a pretty simple bill, and I hope it's pretty simple for us to move through this process.
Thank you so much. Did you have anyone who wanted to speak in support of your bill? Please come forward.
Madam and members of the committee, my name is Leora Brown. I serve patients, families, and fellow surgical team members as a registered nurse in the operating room with 11 years of experience in Hampton, Virginia. Studies on the surgical smoke have identified over 150 hazardous chemicals and biologic contaminants in that plume. Not only is our surgical team exposed to this plume, but the patient is potentially as well. The bill will require protective policies, like you mentioned, and equipment for the surgical team and patients in our care. The device utilizes proper smoke evacuation. Involves an OPA filter, so it is separate from the normal air exchanges that are required in operating rooms. Unfortunately, N95 respirators do not fully protect against surgical smoke either, so it is an additional device that we have to use. As a non-smoker, spending a shift in the OR while utilizing cautery has been equivalent to smoking 30 cigarettes a day. So definitely please support this bill as we already have limited healthcare providers in the operating room, and I would like to safely protect those that are left that care for the populations we serve. Thank you.
Thank you so much. Next.
Brooke Traynor, anesthesiologist, speaking on behalf of the Virginia Society for Anesthesiologists and being a member in the operating room, subjected to this toxin. I just learned something about how many cigarettes I'm smoking a day. So I fully support this bill.
Thank you so much. Is there discussion on the bill at all? Oh.
Madam Chair, Andrew
Yes,
Lamar,
please, go
speaking on
ahead.
behalf of the Virginia Nurses Association. Thanks to the patron for introducing the bill. And I wanted to also thank the Hospital Association for working with us on this, and the substitute that you all adopted included revisions that they had asked for. So thank you very much. Hope you'll support it.
Thank you so much. Any
Recommend reporting.
second? All in favor? Aye. Any opposed? Reports with a recommendation for approval in the full committee. Senator Pillion, you've got two bills in front of us. Which do you wish to begin with?
Let's take 614 by for the week. I'm still working with some veterinarians because of some unintended consequences
Okay.
of this
So
good piece of
629
legislation.
then before us.
Madam Chair, I'll draw your attention and members of the committee to Senate Bill 629. It makes three amendments to the Health Care Provider Fatigue and Wellness Statutory Program that was passed originally in the 2020 session. This program is commonly referred to as the Safe Haven Program, is led by the Medical Society of Virginia. Initially, the legislation was passed to provide these services to physicians, and over the years it's expanded to include pharmacists, nurses, students in respective practices, as well as residents. And my bill expands it further to include dentists and dental hygienists. Secondly, the legislation clarifies that in addition to the Safe Haven program providing counseling and consultative services to healthcare providers seeking care, they may also provide outpatient healthcare services. And finally, the legislation clarifies the reporting requirements that exist today on hospitals when a healthcare provider voluntarily admits themselves for mental health treatment. This legislation clarifies that when a healthcare provider voluntarily admits themselves for inpatient mental health treatment, that if the treating provider certifies that at the end of the day, end of 30 days, the patient provider is no longer a threat to themselves or the public, there will be no report required to be made to the regulatory boards. This legislation incorporates technical feedback that has been provided by the Department of Health Professions, and this legislation is circulated to all stakeholders, and I'm aware of no opposition. If you have any questions, our dear friend Scott Johnson is here on behalf of the Medical Society of Virginia, the Virginia Dental Association, and is glad to address any of those for you.
Thank you. Are there questions from the committee? From the subcommittee? No. If Mr. Johnson would like to say anything, he's welcome to, but I think we're in good shape.
He said it will.
Okay.
He did. Is there a motion?
Recommend reporting.
Second? Okay, all in favor of reporting favorably? Vote aye. Aye. All opposed? All righty. Reports favorably. I think we have completed our docket, and the committee will stand.